In this video, I'm going to explain the components of the Wigger's diagram, which is shown right here. So there are two important components of this diagram. The top part shows you the aortic pressure, left atrial pressure, as well as the left ventricular pressure. So everything is about the left side in the upper diagram. While the next diagram shown right here is the jugular venous pressure, which empties into the superior vena cava, and then superior vena cava empties into the right atrium. So changes in the hemodynamics of the jugular venous pressure is indicative of the changes in the right atrium. So therefore this diagram is indicative of the changes in the right atrium. So first I will explain the first diagram and then move on to the jugular venous pressure after that. So here we have an EKG, which shows you that here we have the P wave where there is atrial contraction. So once we get the atrial contraction, blood will start to flow inside the left ventricle and the mitral valve is open. So at this point, there is an atrial systole where blood is getting inside the left ventricle. And then at the point shown right here, the mitral valve closes. So once the mitral valve closes, by then we have reached a QRS complex, and QRS complex causes ventricular contraction. So now we have the ventricles to contract, but the mitral valve is closed and so is the aortic valve. So the pressure will keep building up inside the left ventricle. So the pressure here keeps building up without losing any volumes from inside the left ventricle. So therefore this point is referred to as isovolumetric contraction because there is no changes in the volume, but then there is an increase in the pressure inside the left ventricle. And so once the pressure reaches a certain point, then the aortic valve will open. And so once the aortic valve opens, blood will start to eject into the aorta. And then eventually, once the blood is ejected and the pressure keeps dropping, then the aortic valve closes. And so by this point, we have reached the ventricular repolarization point, which is the T wave, shown right here. So now the ventricles are repolarizing and are relaxing, and since the aortic valve is closed, there is now isovolumetric relaxation. So the aortic valve is closed and so is the mitral valve. So it's relaxing, there is no change in the volume, but the pressure keeps dropping. And then eventually pressure will drop to a point that the mitral valve will eventually open. And so blood will again start to flow inside the left ventricle, and so the cycle continues. Then there will be again another atrial systolic contraction, blood will go into the left ventricle, and so on. So the cycle continues. And so as you know, the heart sounds lop-dub, lop-dub represent the closure of the mitral valve, and then later on closure of the aortic valve. So here we have the closure of the mitral valve, and then later on closure of the aortic valve. So here S1, which is lop, and then S2, which is dub, are shown with the mitral valve closure and aortic valve closure. Now there are two other heart sounds, S3, which is after the S2 heart sound, and S3 is indicative of the dilated cardiomyopathy, while we also have S4 before the S1 heart sound. And this condition is seen in patients that have hypertrophic cardiomyopathy. Now, as I just explained earlier, the changes shown in these curves are representative of the hemodynamic changes in the left side of the heart. So any problems with the mitral valve or the aortic valve will change the shapes of these curves. And for that, I have provided you with a memory aid that would make it easy. So here, there are conditions that you will have to be familiar with, how they would affect the aortic pressure, atrial pressure, as well as the ventricular pressure shown with the black line. So with the mitral regurgitation, there is too much pressure now that is building up inside the left atrium. And so as a consequence of which, the left atrial pressure will increase. With the aortic regurgitation, the aortic pressure decreases rapidly as the blood flows back into the ventricle. So therefore, you will now see a rapid drop in the aortic pressure, versus earlier curve, which I've shown you, which there is a slow drop in the aortic pressure. So therefore, with aortic regurgitation, you will see a rapid drop in the aortic pressure. Now, as for the aortic stenosis, what happens is that there would be too much pressure that builds up in the left ventricle. So therefore, the pressure of the left ventricle will be much higher than the aortic pressure. And then with the mitral stenosis, now there is pressure that is building up behind the left atrium. So therefore the curve for the left atrium is now shifted up. So here I have provided you with a memory aid that would make it really easy to memorize that. So with aortic regurgitation, we see kind of like an R shape of the shape of a curve, R shape, and then so is with the mitral regurgitation. There is again another R shape of the shape of a curve. With the stenosis, whether it's aortic or mitral stenosis, you can see that the arrows with the aortic is pushing everything down, while with the mitral stenosis, everything, the curve has been pushed up. So these are the changes that you have to be familiar with. And then we have the jugular venous pulse or jugular venous pressure, which is indicative of the hemodynamic changes in the right side of the heart. So what happens is that the jugular vein empties into the superior vena cava, which empties into the right atrium. So any changes in the pressure of the right side of the heart will affect the jugular venous pressure. So A corresponds to the atrial contraction. As we discussed earlier, there is atrial contraction. So therefore, we will have like a bump in the jugular venous pressure. And then after that, since the atrium is relaxing, the curve will keep dropping down. So until we reach the X, which is representative of atrial relaxation. So A was representative of atrial contraction, while X is representative of atrial relaxation. And then we have the point C in between, which is representative of the ventricular contraction. So since we have the QRS complex, there would be a right ventricular contraction, which causes a bump in the curve. If there was no ventricular contraction, then the curve would have been smooth going down like this. But since there is now ventricular contraction, there would be a bump. So after this point, when there is venous filling of the right atrium against the closed tricuspid valve, then the pressure will keep on increasing. So point V represents the venous filling of the right atrium. And then once the tricuspid valve opens, then there would be emptying of the blood from the right atrium into the right ventricle. So that would represent the point Y. And so here I have provided you with a memory aid that makes it easy to memorize all these curves. So point A represent atrial contraction, while point X represent atrial relaxation. And between point A and X, there is right ventricular contraction, which gives the C wave. Now there are also some belief that there is tricuspid valve that bulges towards the right atrium, and that may be representative of the C wave. So in any case, either right ventricular contraction or the bulging of the tricuspid valve into the right atrium is the underlying cause of the C wave. And then we have the V wave, which is representative of the venous filling of the right atrium against the closed tricuspid valve. And then finally we have the Y descent, where blood is emptying from the right atrium into the right ventricle. Okay, now back to this curve again. I mentioned that changes in the jugular venous pressure are indicative of the changes in the right atrium. So you will have to know that if there is a patient with a significant Y descent, then that would indicate that there is probably constrictive pericarditis, which cause a rapid Y descent. While if there is tricuspid regurgitation, then there would be more blood that goes into the right atrium, as a consequence of which there would be a large V wave. So large V wave with tricuspid regurgitation. And then finally, during inspiration, since there is more blood that goes into the right side of the heart, there are certain changes that happens, like for instance, A wave will become larger than normally is. Now there is a condition that is called Kussmaul's sign, where you do not see any changes in the pressure during inspiration. So with inspiration, you do not see any changes. Like for instance, the pressure in the A wave does not increase. And so Kussmaul's signs is indicative of the constrictive pericarditis or restrictive cardiomyopathy, and rarely it may indicate cardiac tamponade. So just keep that in mind. Kussmaul's sign, which means that during inspiration, if you don't see any changes in the A wave, then there is probably constrictive pericarditis or restrictive cardiomyopathy. And so here we have another way of showing the same concept that I just described to you. Here we have the left ventricular volume on the x-axis and then the left ventricular pressure on the y-axis. So once the mitral valve is closed and the ventricle starts to contract, there would be isovolumetric contraction, but there would be no changes in the volume of the left ventricle. Once the aortic valve opens, then that's the time that blood will keep on ejecting until the aortic valve closes. And once the aortic valve closes, then we will have isovolumetric relaxation, which blood does not enter, but the pressure keeps dropping. And then finally, mitral valve opens, and then again, blood will flow in. So the difference between the end systolic volume, which is the line right here, and the end diastolic volume, which is the line right here, is the stroke volume. And so if you're given like 15-20 seconds time on the exam, you would be able to figure out this curve as long as you understand the concept. But in case you want to save some time and just plug everything in, then here I have provided you with a memory aid. So from the starting point where mitral valve closes, you have COCO, co. And then after midnight is the other memory aid. So the top part is A and the lower part is M. So as long as you know AM COCO, you can memorize this sentence, then you're fine. So the lower part, we have the mitral valve closes. The upper part, we have the aortic valve opens. This part, we have the aortic valve closes. And then finally, on this side, we have the mitral valve opens. And so you've got everything plugged in. Now you have to know how changes in the preload, afterload, as well as contractility will affect this curve. So here we had the end diastolic volume, while on this side we had the end systolic volume. Now if there is an increase in the contractility of the heart, then more blood will be ejected out. So therefore the end systolic volume would be less. And so the line shown right here will shift to the left. On the other hand, if there is decreased contractility, like for instance from heart failure, then the line here will shift to the right. With increased blood volume, like for instance from transfusions, there would be elevated preload, so therefore the end diastolic volume will increase. While with the blood loss, like for instance from hemorrhage, the end diastolic volume will decrease. So this line will shift now to the left. As for the afterload, afterload is indicative of the changes in the aortic pressure. So if there is too much aortic pressure, therefore the aortic valve cannot open as easily. So it will take more pressure before the aortic valve opens. And so again, just to remind you, we had AM, co. So aortic valve opens at this point. Now since there is too much pressure, it cannot open at this point, therefore it will need more pressure before it can open it up. And once it opens, there is still too much pressure, so it cannot eject as much. So that would be the change in the shape of the curve once there is an increase in afterload. Vice versa, if there is decrease in the afterload, then the aortic valve opens when there is less pressure, like it doesn't need as much pressure to open the aortic valve. And then since also there is decreased afterload, then the heart can eject more blood for a given pressure. And so therefore the change of the curve would be like this. And then this is the last point I would like to discuss with you, and that is what is the difference between the compensated heart failure versus decompensated heart failure. So with the compensated heart failure, there is decrease in the contractility, so the line is shifted to the right. But you can notice that the change in the stroke volume before and after the heart failure has remained the same. So if you can compare the stroke volume here and the stroke volume before, it has remained the same. It has not changed. And so that's the reason the name compensated heart failure is given to it. And in order to understand how with compensated the stroke volume has not declined, you will have to know the Frank-Starling law, which indicates that contractile force of the heart increases as the cardiac fibers are becoming more stretched. So as you increase the end diastolic volume or preload, there would be more stretching of the heart muscles, and so therefore contractile force of the heart increases, and thus cardiac output increases. So as you increase the volume, the contraction force also increases. There are conditions like exercise and epinephrine that will push the curve up, and there are conditions like congestive heart failure that will push the curve down. And so with the compensated left ventricular heart failure, since there is a moderate increase in the preload, therefore there would be an increase in the stroke volume as well, because there is now increased force of contractility. And so that's how it will compensate for this decrease in its initial contractile force. But then if the heart failure is too severe, then at that point it will be called decompensated heart failure, where increase in the preload can no longer help with the loss of the contractility. So here you can see that the loss of contractility is so severe that this much increase is no longer able to compensate for that loss of stroke volume. So therefore the name decompensated heart failure is now given for this condition. And that concludes our discussion of the Wigger diagram.